Today I am going to discuss principal management of infected long bones. First of all, I like to thank organizer for involving me in this scientific meeting. Yes, for infection and non-union, these three things matter: injury, surgeon, and patient. How? Let's see. Whenever there is a high energy injury, severe contamination, insult to soft tissue injury, bone loss and compound injury, more prone for infection. Similarly, what are the heterogenic factors? Excessive soft tissue stripping by surgeon and inadequate improper fixation. These are the heterogenic issues contributed by surgeon. And what is the host factors which affect or invite infection? Comorbidities, immunosuppression, tobacco habit, obesity and malnutrition. These are the examples. This is a badly contaminated wound. Secondly, improper fixation, inadequate, and lastly, infection. So, what are the problems of infective non-union? One is the infection, second is the poor soft tissue, third is the bone loss, fourth is shortening, and fifth is the deformity. We have to tackle all the things simultaneously. So, what is the aim of our treatment? Our aim is, first of all, eradication of the infection, achieve union without deformity and limb length discrepancy. So, how to proceed? For eradication of infection, we must understand pathology and microbiology of infection, as well as condition of the soft tissue of bone and soft tissue, vascularity of the limb, biofilm formation, culture and sensitivity. Such a nice debridement is essential. Radical debridement, remove all the dead, devascularize and necrotic bone and soft tissue. Also remove all hardwares as we are aware of the biofilms. After debridement, next steps are dead space management and soft tissue cover. For soft tissue covers, we are having option flap, skin grafting, wax dressing, which we are using as per the indication of the patient and situation. Antibiotic plays more important role, paramount important role in the management of infective non-union. As per culture sensitivity, one has to start the antibiotics and it should be minimum for 6 weeks, preferably IV antibiotic. For dead space management, antibiotic beads are used whenever there is no bone loss, and in case of bone loss, vasculate technique is very useful. Remember, for any healing, stabilization is very essential. And second, biology. So, what are the different modalities for stabilization? Temporary and definitive, these are mentioned here. External fixator is very versatile tool which is used in the open injuries for healing of the soft tissue. The application of the fixator should be such that it should not interfere the future surgery and one should avoid the pin track infection. It is the most multifaceted tool in the armamentum of orthopedic surgeon, can take care of severe bone loss by dissection osteogenesis. Similarly, it is very useful for deformity correction and limb lengthening. How one should proceed for bone union? First, confirm there is no infection. Second, provide stability as well as biology. All we know principle of fixation. Achieve direct healing using absolute stability either by plate or net, with or without antibiotic coating. Chairman of Goa IOCON, last year 2021, more than 7,000 delegates had attended the conference. I am sure many of you attended the conference, and presently I am working as a president of West Zone. I am contesting this year for IOA Vice President post, requesting you for your support and blessing. Thank you very much.
Again, thank you, Tosa Khan, organizer, President Secretary and President Secretary of Warangal Orthopedic Association. Today I visited this temple, great hospitality here. Thank you very much again. So we are going to discuss this thought process. This is a small thought process and we'll be learning together. So I may be asking small questions. So this is the typical picture we see. This is been fixed with this plate. Gradually, over the time, it goes into the virus and gets Indian. This is the typical problem. So, what do you think the problem, Prasad sir? Here, what was the problem? Is it a short plate? Length of the plate was the problem? Everybody agree? And medial combination. Yeah? This is the typical problem with the medial combination. Then there is a virus. So there is an instability which remain even after the fixation, right? And probably the cause is short plate, which is what taught to us repeatedly. So now let us see what is wrong here. Short plate. As per the audience, anybody has to differ? Yes, sir. Should I go to the previous slide? Yeah. Yes.
You should put a bendable nail there.
Flexible nails on the medial side. When there is a combination, you need some medial support.
Yes.
So there was some invisible instability remained after the fixation, and that was not noticeable on the table by the surgeon. Right. This is a typical problem. So now let us see what is happening here. Now it is okay, sir? Prashad, sir? Do you think the length of the plate is okay, sir? Length of the plate, and as per the principle, screws are divided. Do you want a still longer plate? So always, primarily you put medial support? All the fractures? Everybody agree? Primarily you put a medial plate in the such cases? So surgeon was right here or wrong? Reduction, what is the problem in reduction, sir? Plate location is? It is pushing medially or it is just a combination here? It is aligned, almost aligned. Plate is not controlled according to locking plates are controlled? Yeah. So according to the different anatomy, it may not contour, may contour. But the principle has been used rightly, I think. There is a gap here. It has gone medially. Okay. No, sir. This is whole combination, sir. Here is the lower fragment and here is the proximal fragment. In between, whole metaphysis has been combinated. Intra-articular part has not been reduced properly. We forget this. We are considering this as far as the length of the plate is concerned, sir. Okay. This is what happened gradually, and this is happened, and ultimately it united, but it united the virus. So, what was wrong here? Long plate? No. Not enough stability. So it is not a short plate or long plate. We are taught that you use the long plate, so it will give a good stability and will get a good callus. Right. Right. Another. Again long plate, but surgeon has put a graft, artificial bone, and no structural graft. It was requiring a structural graft, right? So there is a red flag whenever you see such cases. Is it possible minimally invasive to give a medial support, as Dr. Sir has said? In a crumpled bone of elderly, when there is a minimal combination, but it is an elderly bone, it is a crumpled bone where you can do with the flexible nails, as Sir has said, you give a medial support with a flexible nail, which goes further and further, with a small incision on the medial side, and that will give a medial stability. And here, you get a good stability, and this is a small medial incision here, you can see here, and it gives a good function. So the concept is a medial loading. Medially loading is occurring continuously, and that invisible instability, small amount of the instability even after the fixation is remaining. And here, this gives a micromotion probably, and that's why it gives some callus good on the medial side. The problem with the locking plate was deficiency of medial callus. Right? So if we go further, 16 weeks. Yes, this has been operated by one surgeon. Now it has come to you, sir, Prasad sir. What will you do? 16 weeks. What do you think? It's the short plate that is the problem? Lot of valgus is there. You're right. But it's not showing any sign of the union here. What will you do at the 16 weeks? Bone graft. Anything else? Medial fixation, right? So it is asking for the stability and the biology both. So, small plate on the medial side and the fibula as a structural graft has given a good result without changing the plate on the medial lateral side. Many suggested that to change the plate to the longer side. But if you add a stability on the medial side, even the short plate will work. So this is the result at 12 weeks, and this is the clinical picture, right? So again the same case. Here surgeon put a non-structural graft and the plate was broken, and there was a cold welding, so it was very difficult to remove also. Titanium implant, again fibular graft and a medial plate, 2 screws or 3 screws below and 2 or 3 screws above. Just give a support on the medial side, and that gives a good result. What is happening here? What will happen, sir? Do you have? What will happen? Still there is instability? What will happen? What is the course? In such type of fixations, what is the course? What will happen, sir? We'll remove the implant now. What will do the fate? Union will occur or not? It will be a failure. What type of failure it will be, sir? Non-union. Okay, let us see. Usually in these cases, we have to wait for 6 to 9 months after the fixation, because it takes a longer time to consolidate, and you can see that gradually it has consolidated very well. Fantastically consolidated with the added stability. And this is the previous scar, and this is the modified Schwarz-Buckler approach to go medially also together. This is the previous scar, this is the new scar, and this is the fibula. And this is the function. So, aiding a whatever invisible instability which you are not able to understand on the table, that has to be taken care of. That is the message of medial instability. Now the question comes, many surgeons are asking, how far I can go medially? There is a beautiful paper by this gentleman where he has divided this area of the femur, where you can go up to here, there is no problem. We go up to here, put a medial plate. If you have good dissection, you can go up to here medially. If there is a combination, you can go medially up to here. So it is safe here. This is the paper. Note down this paper. But it is very important where to put and the length of the plate on the middle side. That is also very much important. Just putting the plate will not do. This is one example where patient was not ready for the fibula, not ready for anything. Then we put an intramedullary plate as a medial support, as a lost implant. You can see here, screws we targeted from here to this hole, and that has given a stability, and that has given a function. So this is also a possibility, but patient should be warned that it will be a lost implant. You cannot remove, just like in proximal humerus. These are all theory, working length, rigidity of construct, strain, micromotion, we all know. Where to span, how to span, what is the fracture length. But many times it is very difficult to understand on the table for individual fracture, individual case. What is the stress and strain? What is the gray area or what is the zone which is required for that case particularly? We cannot follow completely theory. We can follow the principle. So now, for this problem, the AO had come with this implant that is the flexible screw, far cortical screw, which is flexible. You can see here in this video, it is flexible. So it allows the micromotion and it allows the medial callus also. This has been already tried in the literature of far cortical screw, where there is a sleeve inside here in the screw and that allows the movement. And you can see there is a movement here of the plate on motion, on the axial loading. But this is also not worked. This experiment has been tried multiple times. So surgeon has a dilemma always to reduce the wrist plate failure and optimum interfragmentary movement. Surgeon has to balance each case. So we have to learn from the nature also. And this is the new development to have a biphasic plate, where the thickness of plate is here is different, and there is a slot to get the...
Dr. Amarnath sir. Dr. Ajit Shinde sir. Dr. Ajit Shinde sir. Dr. Anup Agarwal sir. Dr. Anup Dr. Chandrasekhar sir. Dr. Chandrasekhar sir. Dr. Maheshwar Reddy sir. Dr. Maheshwar Reddy sir. Dr. S. Mohanty sir. Dr. S. Mohanty sir. I request Dr. Ramkumar Reddy. Dr. Konneru Rao sir. Dr. C. Ramu sir. Dr. C. Ramu sir.
proceed to our next session, conference orations. We call upon TOSA President Dr. PNVSP Prasad Sir and TOSA Secretary Dr. Vijay Bhaskar Sir to grace the stage as chairpersons for this session. Now we proceed. Thank you, sir. Now we proceed with the main oration of conference, Dr. Vedula Satyanarayan Murthy Memorial Oration, with the permission of TOSA President and TOSA Secretary. Ceremonial function by lighting the lamp. We request all the delegates to accompany sir.
సంస్మరింతుము నిన్ను నిత్యం మామనో కుసుమాలు పూజను నీదు పదముల నర్చించనేడు సస్యమూర్తి అమృతవర్తి సంస్మరింతుము నిన్ను నిత్యం మామనో కుసుమాలు పూజను నీదు పదముల నర్చించనేడు మాధవుని భావాల రూపం మసలనేమో మీ మనస్సున ఆర్త సేవను సంఘ సేవకు మేళవించిన అమృతమూర్తివి ధ్యేయ పథమును వీడకుండా సంఘ మంత్రము మరువకుండా సంఘ జీవన సరళిదియని సరళముగా బోధించినారు సత్యమూర్తి అమృతవర్తి సంస్మరింతుము నిన్ను నిత్యం మామనో కుసుమాలు పూజను మీదు పదముల నర్చించనేడు వేనవేలుగా ఆర్తజనులా పాలితా నారాయణుడవు దిక్కులేని ధనం లేని పేద ప్రజలకు అభయమూర్తి మిమ్ము చూసినంతలోనే వ్యాధి వ్యాకుల పడెడు నందురు మీదుహా అభయమై కనపడునటందురు సత్యమూర్తి అమృతవర్తి సంస్మరింత్యం మామనో కుసుమాలు పూజను మీదు పదముల నర్చించనేడు సత్యమూర్తి నీదు దేహం సత్యమై సాకారమందెను సేవకే పరిభాషయయ్యను ఆదర్శ జీవన కుసుమమయ్యను భరతమాతా మీదు సేవకు మురిసిపోయను ప్రతిక్షణమునా బాలికై మీ సేవలంది హసితయై మీ సేవలంది పరవశించను మనసునందున సత్యమూర్తి అమృతవర్తి సంస్మరింతుము మిమ్ము నిత్యం మామనో కుసుమాలు పూజను మీదు పదముల నర్చించనేడు.
Now we request Dr. C. Raghuram sir to honor Dr. V.S.N. Murthy sir with garland. We also request all the delegates to honor Dr. V.S.N. Murthy sir. Now we request Dr. P. Kali Prasad Rao sir to read the biodata of Dr. V.S.N. Murthy sir. The student of KM.
To read Dr. Veda Satyamurthy biodata I am his student. Professor Dr. Veda Satyamurthy was born on 15 February 1951 at Kottapeta, East Godavari district. He was the fourth son of Sri Venkatrao Garu and Srimati Lakshmi Kantamma Garu. His primary schooling was at Kottapeta and took his admission in MBBS at Andhra Medical College, Vizag in 1967. Post-graduation in orthopedics at Andhra Medical College. He joined as assistant professor of orthopedics at KMC Warangal in 1978 and was promoted as a professor of orthopedics in 1995. He is a selfless and dedicated, competent orthopedic surgeon, used to work in the hospital round the clock. He trained so many undergraduate students and postgraduate students. He is a perfect disciplinarian and true gentleman to the core. He conducted various polio surgeries, tumor surgeries, apart from trauma during his service. He started total hip replacement in MGM Hospital, Warangal. He is the person who started Meyer's muscle pedicle grafting procedure and produced a number of papers in both and state and national conferences. He is a great social worker and involved in RSS activities in the town. He is the first person in the state to do titanium prosthetic hip replacement and pelvic reconstructive surgery. He used to attend all national and state conferences and national CMEs at various places, and he was awarded the Best Participant Award at Indore National Conference. In 2001, he was diagnosed with primary hepatocellular carcinoma, for which he underwent hepatic transplantation at England. After returning from England, he resumed his services and conducted all major orthopedic surgeries as before. He expired on 30th March 2003 with pulmonary secondaries. The students and disciples of Dr. Vedra Satyamurthy Garu are conducting CMEs since 2004 till date, and this happens to be the 16th year of CME. In KMC, the students are organizing football tournaments in his name. They are also conducting blood donation camps in the name of the great soul. We salute Professor Dr. Vedra Satyamurthy Garu for his exemplary, committed, selfless, free service to the humanity. Thank you very much.
I know what the department was before that, before him and after he has taken over. He has inculcated ethics into the Department of Orthopedics, and the same is being continued by its dissidents in a much better way. That's why the college and hospital are running in a very ethical way in MGM. I congratulate all of them. Now I call upon Dr. Naresh Shetty to come out to the dais for his speech.
To dais, lecturer of orthopedics at MS Ramaya Medical College, Bangalore, from 1986 to 1990, professor in the Department of Orthopedics at MS Ramaya Medical College.
Luckily, they stopped in 1994. Can I have the first slide, please? I think coming for an oration of a man who has distinguished himself for 4 decades, and then when we see the students actually showing their love and showing all that blessing that they are talking about, I think it's very difficult for me to actually come anywhere close to it. But I think I will try my best to make some difference at the end of this talk. Can I have the... I think from the morning we had all kinds of talk going from the hand to the hip to the knee to the fractures to the recent trends to to the fractures, and then finally Naveen come up with the latest plates that he's talking about. Actually, Dr. Amarnath speaking about innovation, because that's the way to take our country forward. Why did this name come, or how did I choose this title for this topic? Where is Rakesh? Yeah, I was sitting in a coffee shop and Rakesh was insisting, please give me a topic, please give me a topic, please give me a topic. And I looked up and I said, a lot can happen over a coffee. And that's how the title came into being. And you know, the person who started it all was made in India, Indian. But also a lot of people would have gone to Starbucks, many of you. And what was his theme of Starbucks? He said, I want anyone who does not go to his house or to his office to come and sit in Starbucks. That is his third place. A place where we can discuss, a way we can dedicate, a place where we can dream of doing something different. And so, as I was sitting in the coffee shop, I was talking to one of the biomedical person from Indian Institute of Science, and we are talking about new composites that can come about over a period of time. And as we are talking about different composites, then he was talking about the whole process that goes about. And when Amarnath talks about the process, I understand what he's talking about. And then quickly, at the next moment, he told me, do you have process in the way you treat patients? And so, science may always come up with some better office communication system, but nothing like coffee back. That made me think. I did tell him, we know what to do. The process is there. Then the next question he asked, do you actually implement those processes, or is someone looking at those processes? And I had no answers. This was basically, if you look at the technology and innovation, which is one of my favorite topics, the game changer of the next decade. And I had done an editorial 2 years back in our journal. And I cited a lot of points that can come up over a period of time. And that was my first topic that I was going to talk about. And then, somewhere around in March, I got this. The most serious and avoidable errors of 2021 happening in one of the most advanced countries, the UK. And what it said, surgery performed on the wrong part of the body, 97. Foreign object left after procedure, 90. Wrong implant processes, 46, and so on and so forth. That means there were a lot of errors happening. We are actually going on a trajectory, but we do not know what we are actually doing. And this set me thinking. I said, are we doing the right thing now by talking only about technology? So I changed my topic. I said, I'm not going to talk about those topics that we started with. And I thought about it. Technology is no match for human errors. And I believe technology cannot match human errors. And all human errors, why do they happen? Because of our impatience, because of things to do fast, because of persistence to do something wrong. Because at some point of time as surgeons, we think we can do wrong, no wrong. And we actually act like gods at some point of time. And that's why errors do happen. And I looked at the data that's coming in. Indian medical error deaths, nearly 5 million a year, can be cut by 50%. No one talks about it. Everyone keeps quiet because all of us go through some problem or the other. It's not only in India, it's all across the world. Deaths due to medical errors in US. It could be because of medication errors, it could be during the childbirth and pregnancy, it could happen because of surgical errors, or it could happen about misdiagnosed condition. Everything is error. Now let's look at it. Errors are not negligence, they are not intentional. So I think we need to make a basic difference between these two. And one more highlight. The third most cause of death in US is medical error. 44,000 to 98,000 causes annual deaths. Medical errors are the leading cause. More Americans die from medical errors than from breast cancer, AIDS, or car accidents. And 7% of the hospital patients experience serious medication errors. And the cost is anywhere between $8 to $20 billion annually. So what is the federal action? We said, let's get it down by 50% over a period of time. And one more damning report that came about. Healthcare today harms too frequently and routinely fails to deliver its potential benefits. What does it say? We have the potential, but somewhere down the line, we make compromises in the way we treat people. It is said that safety and performance improvement is a journey that never ends. Poor is human was a statement made long time ago. Today people are not going to accept. Improving the safety of healthcare delivery is very, very important. And more important, the errors are never intentional, but invariably due to failures, due to poor judgment and lack of leadership. The difference between ordinary and extraordinary is that little extra. And that extra care, that extra caution is the only thing that's going to make a difference between all of us staying as ordinary surgeons or becoming extraordinary surgeons. I'll just stick to surgery today because I think most of our surgeons and we like to cut well, and we want to have good outcomes. 10 commandments. 234 million surgeries happen every year. 1:25% per year. Surgical accident reported, unreported. No one knows in India. And so, the World WHO made a guideline for safe surgery in 2009. And one of the major proponents was Dr. Atul Gawande. And I think all of you have read his book. So many books he writes, some of those classic books that all of us must read to understand what we are talking when we talk about medical services in the best of the world. So what are the 10 basic objectives? Number one, the team will operate on the correct patient at the correct site. Now everyone would say, that's a common thing, and what's so big about it? Absolutely. In 1995 in Florida, first time an amputation was done on the wrong side, and it became a big news. And from then on, the medical services got into the lens. People started looking at, are the medical people doing the right thing always, or they're doing something wrong? This became a big controversy at that period of time. And so it's good that you follow some universal protocol, and this is good for all the young people who are sitting here. Is number one, consent form, the site to be very, very specified in the consent form. Always ensure that the marking is done next to the operative site or on the same limb. Unambiguous, clear, visible, and made with the permanent markers, because once you have draped the patient many times, you won't know what's happening. Made by the surgeon, preferably performing the procedure. Recheck before anesthesia when the patient is alert and awake. Time out. A brief pause before you take the final decision. Confirm the patient, procedure, and site of operation. Now, I think many a times when once the patient is draped, we tend to know that the patient is draped or not. And I think especially, and Raghav will know, in spine surgery, the levels. We tend to sometimes not know the exact level, and we tend to operate. And it's happened earlier. We tend to operate one level higher or lower, and then we corrected it. So these are things what we need to be very, very clear, because we take things for granted. A wrong-sided brain surgery in the same institution 3 times in one particular year. And if anyone knows about Sri Devi, and the mother was operated in the north side, and it made big news at some point of time when we were young. The team will use methods to prevent harm from administration of anesthetics while protecting the patient from pain. This is the common headline that you keep on seeing. Why does it happen? You ensure that your anesthetist friends do all this checklist. And more important than that, I want you to ensure that your anesthetist friend sticks with you right through the surgery and do not allow him. A time has come when, because of technology, everything is monitored, and most of the anesthetists sit outside in the lounge, have a cup of coffee, and when the time is required, they are not there. Never allow that. Tell them to have coffee. You can have them coffee with them, but don't allow them. During the surgery, they need to be there with you. Just an example. An anesthetist leaving OT immediately after extubation, patient dies. This happened in Delhi. Primary consultant found guilty. Allowing anesthetist to leave without verifying his table is deficiency as per the services, as per the Delhi Consumer Forum. So what happens? We have these anesthetists which keep on going from nursing home to nursing home like bee on the flowers. You have to finish before that, they have one more going on. So most of the time in smaller places, and all the people who are working in nursing home, be careful. Don't allow the anesthetist to go until you are very sure the anesthetist is shifted to the ward. The team will recognize and effectively prepare for life-threatening loss of airway and respiratory function. I do not know how many people remember one of the famous, well-decorated surgeon in Bombay who had to go through a lot of issues, medical legal issues. During his spine surgery, the tube had slipped, and when he was turned around, that was the time when they noticed that the tube had slipped. So, the primary surgeon, watch out. Especially, it is good that the surgeon actually is involved in position of the patient. And this is very common in spine surgery and shoulder surgery, especially in the V chair position that we are talking about. And as recently, 3 years back, we lost one of our students who had gone to one of the corporate hospitals to get his shoulder operation done. And as you know, they allow...
Sir, and Dr. Vijay Bhaskar sir to honor Dr. Thank you, sir. Now I request
President Harris.
Good afternoon all. Respected President TOSA, Dr. P.A. Prasad sir, Secretary Vijay Bhaskar sir, I stand here before you presenting my presidential passport oration in contemporary practice in orthopedics and updating with time. Honorable members of Telangana Orthopedic Surgeon Association, ladies and gentlemen, it is with immense pride that I stand before you on this august occasion of annual conference of TOSA to present my past present oration. As I come to the end of this very gratifying period of my life as president of TOSA, I would like to go through my experiences and how to match contemporary period of practice successfully. This is one quote I like very much. Tell me
I forget. Teach me and I remember. Involve me and I learn. This is by Benjamin Franklin. So I involved myself with TOSA, initially with TOSA. My journey started with Orthopedic Association from 2009, where I given my services as treasurer for 6 years, and then secretary for the OSA 3 years, then secretary for TOSA for 3 years, then president. I wish to express my appreciation to all of the great teachers and seniors who have involved me and preceded me in this association. It is with their inspiration that I have worked as a treasurer, secretary at TOSA, and now as president of TOSA. I have endeavored to emulate the standards set by them. I thank them for inspiring me and challenging me and strongly influencing my career. These are my teachers from school till now. The first Usha madam, she inspired me throughout my school education. When I was very naughty and doing very robust, she made me studious and I stood first in my class. Professor Ravi Shankar sir, he was my teacher in my PG in JSS Hospital, Mysore. He used to teach us. His rounds were very lively and humorous, and he has made us learn what discipline is. And when I joined my DNB in Hyderabad, in Durgabhai Deshmukh Hospital, I worked under 3 teachers. I was the only PG there. Dr. Ramu sir, Dr. Vaisan Murthy sir, and Dr. Ranga Reddy sir. And I was free in the evening. I used to go to Dr. Rangachari sir, Professor Rangachari sir. We used to do long hour surgeries, 8 hours, 12 hours, spinal fixations. I used to assist him. I learned what is surgery at that time. And Ramu sir, he has made me learn how to tackle the patient's cases, and whenever a complication comes, how to tackle it. And in between, I used to go to Sir Dr. Vedprakash sir, Dr. Ravadat sir. I still remember the rotis made by madam. We used to have the home food there. Thank you, sir, for that. And Professor Dr. PVC Reddy, when I came to Warangal, he has guided me and he has brought me into this association, and he made me learn how to work with all the principles of association. And Professor Dr. K. Ramkumar Reddy, he is here before us. Any problem, any problematic case, he is there with me. These are my inspiration. I like them very. I like to be with them. I spend my time with them, and love them. Now that we have come to orthopedics, which is redefined in this few years, and orthopedics in India has flourished in several ways in the last few decades, and this process has achieved fresh momentum over the past decades. A lot of changes have happened. This has been a golden period of orthopedics, particularly in the state of Telangana, where the subspecialty practice, which was once limited to the major cities, have spread to the district areas. This is a tribute to the senior teachers and surgeons of this august association who adapted their knowledge and training according to the local needs and facilities, and most importantly, pass their knowledge and their expertise to the subsequent generations. So through a lot of CMEs, workshops and all. These eminent stalwarts have ignited a spark that has reached far and wide and raised the standard of orthopedics in our state on par with that of the world. While we strive to improve our standards, we should never forget the common man, who requires the same quality of care at an affordable cost. That's what the Aragyasri scheme is about. So we are offering corporate services at our hospitals, 50-bed hospitals, to all the BPL people. After my post-graduation from JSS Mysore and DNB course from DD Hospital, Hyderabad, I returned to Warangal in 2003. I was updating myself and my hospital since then. This was a picture of in 2003. I have renovated at that time when I came, and in 2007 I have renovated again to get the state government reimbursement, and again in 2016 to have built 2 OTs, and now in 2021 I have built this one. This is my OT. These are all These are all my OT pictures. I always had a urge to learn and update myself. I never stopped and looked back and always updating my knowledge and attending various CMA programs, workshops and conferences. This helped me to successfully establish a 50-bedded hospital with NABH recognition and all insurances with set good standards to deliver efficient patient care to the required. Now there is a transformation of techniques when I used to be a PG and now. I would just like to quote a few. The open fractures, there was a time when open injuries had bad results to now where they're better managed and better results have emerged. What changes is the approach and technique to address it with evolving evidence and knowledge and how best to treat them. Knowledge is like continuous software update, how your phone gets updated each and every month. So you have to update yourself through a way of CMEs and workshops. So antibiotics assist only after timely debridement and stabilization with early mobilization. Newer approaches and modern ways to handle many complex scenarios with better results are in practice today. This is like the timely debridement and stabilization fracture with Elizarov or muscular technique has given wonderful results for this difficult fractures. Now I have been interested in VAC therapy, which was started way back by Dr. Amarnath sir. I used to treat a lot of cases of necrotizing fasciitis and all, diabetic foot and all. So when I had a problem with that, I asked Dr. Amarnath sir to help me. He has detailedly given me the beautiful advice regarding this VAC therapy, and we have indigenously developed in my own hospital. Then later, now so many appliances have come down. These are all the indications for VAC therapy. So these are some of the cases which I have done in my hospital. This is a case of initial wound, 14 days of VAC therapy and 22 and there is a 22nd day of VAC therapy. Then we have done a grafting. This is a case of open fracture where I have treated and by thorough debridement along with the plastic surgeon and fixed the fracture and applied VAC therapy, and these are 21 days. After 21 days, this is a complete granulation achieved, and after 3 weeks of VAC therapy. And we have done a grafting, and this is a case of post amputation. There was a huge infection was there, and we have done debridement and VAC. We have applied VAC. The granulation issue has come down, and these are the final result. This is a case of venous ulcer where we have put VAC and then we have grafted it. These are all the cases where I have done this debridement, good time of debridement, then VAC, then grafting. Now the recent advances in Elizarov methodology and limb reconstruction. This is a SU frame and Taylor's facial frame. These are used for non-unions, and this muscular technique is used for wound debridement and cement spacer application along with the patent stabilization. These are used for infected gap non-unions, which have very good results. The internal fixation is also used for limb lengthening, like telescopic nails and external remote control devices, which are very patient friendly. The limb lengthening can be done over plate also, and with a short-term Elizarov fixator or the latest ERCs is another option. Deformity correction with internal fixation is also being done with or without fixation, which is more patient friendly. But despite so many advancements in Elizarov and limb reconstruction specialty, Elizarov ring fixator remains the mainstay of treatment in Indian scenario, which is more economical and time tested. When we were PGs, the only way of treating IT fractures is DHS, which is very user friendly when we learn the technique in a proper way. Now we have PFN, which is the implant of choice for IT fractures, but I use it only for unstable fractures and reverse oblique fractures. As PFN evolved to a better implant, switching to PFN, it has a very long learning curve. But such learning curves can easily be easily we can forego that by attending the number of workshops and learn new implant strategies. The proximal tibial fractures, when we were treating them, we have this, we are treating them according to Statskas classification, but now the 3-column classification has evolved and we are following this 3-column classification involving lateral column, medium column and posterior column, wherein we are fixing the posterior column fractures also. The robotics in spine surgery has evolved a new specialty now. They are doing a lot in Hyderabad. The purpose is minimize surgical errors and increasing the patient safety. The spine surgery is now, the conventional spine surgery is laborious and has a lot of time taking. In robotics in spine surgery will minimize surgical errors and increase the patient safety. The shared control system allows the surgeon and robotic arm the stereotactic trajectories based on pre-op and intra-op imaging. They perform repeated grafts with virtually unlimited endurance. The pros are increased accuracy, decreased radiation and operating time. Whereas the cons are that it's a very expensive procedure, motion related artifacts are there and a very long learning curve. The recent advance in hand surgery, this is a recent picture of a case where the hand was amputated and re-implanted from a surgeon from Hyderabad, Dr. Sunil. The hand surgery is evolving as an entirely new specialty. Now it is at a crossroad between orthopedic, plastic and microsurgery. And the wrist orthoplasty is also gaining importance now. Common indications include the TFCC, TF, scaphoid fractures and synovectomies. As the previous speakers have told, the osteonecrosis of the femoral head, there is increasing evidence, especially after the COVID pandemic. Now, I have done 2 cases of two young adults who have suffered COVID and now they were on corticosteroids and now they have come with osteonecrosis of femoral head. The recent studies have shown that the hypercoagulability and microembolisms due to the dead COVID virus particles is responsible for the formation of AVN. One of the studies conducted in our own Telangana has shown the beneficial effect of hip arthroscopy, core decompression, intralesion BMAC and zoledronic acid in this patient. These are clinical pictures of hip arthroscopy wherein the cartilage is lost. And this is a surgical technique of core decompression where the guide wire is passed under fluoroscopy. Both AP and lateral pictures are taken, drilling is done, scooping is done and BMAC is applied. Recent advance in arthroplasty navigation is gone and robot-assisted joint replacement has taken place, which is very precise and accurate in bone cuts and ligament balancing. It's a fast-track procedure where same day of walking is allowed because of a better quality implants, surgical techniques and pain management. In the same way, unicondylar arthroplasty is for isolated middle compartment osteoarthritis is also have better results and rehabilitation when compared to TKR. Patellar resurfacing is also gaining importance for the patellofemoral arthritis. These joint preservation techniques are evolving in a new way. It can substitute joint replacement option for arthritis. Now due to advancements, especially in younger patients, we have many options available. One is cartilage resurfacing with autologous compensated implantation. The benefits are they provide hyaline-like cartilage can be used for large defects. The limitations are there are 2 stages and very expensive. The second method is osteochondral autologous transfer, which is a single stage procedure but limited for small and medium defects. Orthobiologics gaining is a very important topic now. There are many workshops are going on, and this is Dr. Amarnath sir told regarding the platelet-rich plasma, which is a specialized blood cells which are the reservoir of growth factors. The indications are ONE, tendinitis, partial thickness tendon tears, augmentation of ACL, hip AVN, plantar fasciitis, bursitis, and degenerative disc diseases. The bone marrow aspirate concentrate is obtained from the bone marrow, which is constituted stem cells, and from which the stem cells are separated, and they are used in non-unions, osteochondral defects, AVN and spinal fusions. Apart from orthopedics, they are used in ophthalmology and cardiovascular and vascular paternity also. Now I am going to deal with the practice-oriented thing, the doctors and the noble crucifixion. Our society always calls the doctor noble, but crucifies him for various reasons. Main thing is money. The advent of modern investigations have always been a boon to diagnose a patient, but they come at cost. Also, the modern hospital infrastructure and space of hospitals have hiked the cost of healthcare a lot. Also, remember the numerous tax we pay to the government, which is consuming about 50% of our income. All these factors have drastically increased the cost incurred to the patient and label us as high cost surgeons. Remember, ours is the only faculty wherein we treat freely. Take any other profession, whether they are engineers, whether they are auditors, whether they are anyone, they don't give their free service. We are the only people who give our services free. Cost of a hotel room and a hospital room. So we are providing all the facilities in a room, but our room rent is matching to the hotel room. We provide all kinds of monitors, oxygen, everything, but our rooms are in par with a hotel room. But the patient thinks twice that we have to pay that matter, and they think that we have to keep the price at a lower price. Regarding the quacks, this problem will be borne by all. We will face in our profession when we go to the practice. In 2002, on one side, we talk about the development of the country and society, and in our field, we still see quack treatment happening in various forms. Take them in TV or ads, paper, or in roadside people. They are all quacks. These traditional procedures are also using advanced X-ray machines and CT scans. And people are disillusioned and have diminishing confidence in us, ending up in the hands of the alternative medicines systems and quacks because of our high cost therapy. Patients who think right medical treatment is expensive, and they go to quacks and land up in problems. The term quack itself is a very broad and controversial title and topic. The problem lies not only with the public or the media, but it is a time we reprise ourselves, not just our techniques or technology, but our approach, our relationship with patients and their relatives, and our general attitude about ourselves, which can sometimes make public not to go to alternate system practice. We should devise ourselves that whatever patient comes to us, we should satisfy him with our facilities, with our talk, with our system of medicine. We should not lose it. The proper communication with the patient and attendance is very important. The doctor-patient relationship. It is this relationship that has lifted our profession and make the doctor worthy of respect and worship. Whenever we go into a society in a party, Dr. Sahab has come, give him some place. That is the respect we gain. There is a steady erosion of the relationship in this current era. The selection of the general decline of moral standards, the changing nature of professional practice, materialism and commercialism. This will happen because we will be reading for 6 years for MBBS, 3 years of post-graduation, then for super specialty, then for a fellowship. After 15 to 20 years of study, we go there, sit in our chamber, no patient comes. We should do all kinds of advertisement, all kinds of CCs and all to get a patient. Yesterday patients have become today's consumers. And how should we generate our income? The doctor is seen not as a divine healer but as a healthcare provider, and the society looks at a hospital as a trade but rather than a profession. And this has a big problem, Dr. Google and Mr. Internet. In this era of globalization of information, the patients have access to the reliable information about the problems via Internet and Dr. Google. Everyone must have experienced it when the patient has come to your clinic and said, the Google says this thing, sir. They have become more aware of the development of technology and medical science, and they rightfully demand the best care and choice of implant they have. Unfortunately, they also have access to misleading marketing information and annoyance. In one way, this is useful to ask the patient to confirm our suggested treatment methods, complications, and alternate way of treatment. Because some patients don't believe us. We tell them what are the methods of treatment we have, what are the complications, and ask them to see the Google and annoying has now become easy with preset questions from Dr. Google and unwanted doubts from Mr. Internet. The answers to Google questions, how to answer them. Although it is our duty or responsibility morally to answer and clear all the doubts in the patient mind, although we are annoyed, there has to be a differentiating line to avoid bad relation with them. We need to deal in such a way that the relation with the patient is not strained by his annoyment. We can shout at them, we can be annoyed with his foolish doubts, but I have stopped doing that. Initially when I was in practice, I used to shout at them, I used to be very angry with them, but now I just listen to them, I give a smile, I just answer very coolly, and I leave them. The balancing is a very tough job, and mastering that art is only with the experience. Never lose your cool and answer very humbly rather than harsh, which saves your energy and health. And the doctor-to-doctor relation, we must stand united amongst us in the community and keep the orthopedic family together. When I came to Warangal in 2003, whenever there is any problem in any nursing home, whether it may be orthopedic or any nursing home, we are a team of doctors, we go there, we fight, we stand with the doctor and fight with the people. This will enable us to keep our profession focused on the welfare of our patients and also withstand the assault on us by the society. OSA and TOSA has been kind enough, and always my orthopedic fraternity has been supportive to me to be successfully be the secretary and president of this association. This is some of the photos from the TOSACon 2018 where we enjoyed a lot. The doctor-to-doctor relation, I sometimes wonder if we could learn a lesson from the legal profession, wherein during a case argument, lawyers aggressively attack each other, but as soon as the court case is over, they maintain a degree of professional respect towards one another, despite the competitive nature of their profession. Let's not make rude or demeaning comments about our colleagues in public or in front of patients, or don't make any signs also. Seeing an X-ray of another surgeon, don't give any pause or anything. Rather, let's use proper forms of peer review within our professional organizations to criticize constructively when we believe that's possible. Care has not been provided. And this is my bitter experience. I have come alive again. One team of goons, they tried to damage my reputation and blackmail me in 2019. They came, they pretending as patients, six members gang, 3 ladies and 3 gents. She came to me for the problem of backache. When I was about to examine her, she shouted, and the remaining patients in my OPD room, they also came up and asked me, why are you misbehaving with her? They created a lot of galata in my hospital, and I was just cool. I was cool. I was not talking, I didn't tell anything, I was not scolding them, I was just listening to them. I thought I just knew they have come with a plan. These people, I have explained them what has happened, but they didn't believe. The patient, the husband has come, I have explained him, and 2 more people have come, I have explained them very coolly. Then they went to the police station and tried to keep a case on me, police case. And it has become viral over the social internet. They have taken a video of an argument and they have made it viral through the social media. Then one friend of mine, he has called me. This video is coming in all the groups. Do you have a CC camera? Yes, sir, I have the CC camera. Then take out the thing and you spread it. I had this video. You can see in the Google, YouTube. This is if you type Balaji Hospital, you'll get it. Balaji Hospital, Warangal, you'll get it. I didn't touch the patient also. She made a galata. So I have taken this CC camera footage to the police station press where they were waiting for me. When they showed when I showed them this footage, everything became silent. And I have made it viral to all the groups. And what was negative to me, it has become positive. And our secretary, Vijay Bhaskarana, he has helped me a lot in this case. And the goons were taken care of. And being updated with advanced technology like CCTV in your hospital will save lives. If not for the CCTV on that day, I would not have been standing here now. And my services to the society, like just like the Mahesh Babu told, ఊరిని చాలా తీసుకున్నాం, తిరిగి ఇచ్చారు, లేకుండా లావ్ అయిపోతాం. Even though I'm doing a lot of service to the people. So as I've served all these organizations, TOSA, OSA, IMA, TANA, Lions Club, Rotary Club and Vasavi Club. Just few of the photographs, TOSA activities. These are last 2012-18 in banquet night here. Atul Srivastava sir is there. This is the executive body meeting. This is the TOSACON. Prakash sir is standing there. KJ Reddy sir, VC Reddy sir, Jairam Chandra Pingle sir, Ravi Babu sir, VS Reddy sir. Seeing them gives a nostalgic moments. This is when I became IMA president. We have done a lot of work for IMA. Lot of free health camps and education programs have been conducted. And for Lions Club, this is one appreciation from the IMA, state IMA, on the Doctor's Day last year. And we never forget Bone and Joint Day. Every Bone and Joint Day we conduct one or the other program in Warangal, like walkathons, cyclathons, BMD tests. We always celebrate IOA activities. And apart from this, I always spend my time for myself in the morning. Whatever it may be, I don't give it to my family or friends or anyone or hospital. I spend it for myself to be fit. I play shuttle badminton, and these are my awards recently. When I won 50 plus runners in Khammam tournament. This is in Warangal. Both are in Warangal and one is in Khammam. And now I am the vice president for the zone Tana. And he is my father, late Dr. P. Suryananda, who established my hospital in 1978. He is a poor man's surgeon. He used to take 150 rupees for any surgery along with the medicine, and used to give the money back to them for their work. She is my I lost him in 1996 when I needed him the most, but he's still with me always. My mother, Rama Satyavati, she takes care of me still today. I love her. This is my family. I'm blessed with my wife, blessed with 2 kids, and my wife Madhavi Lata. Dr. Venkat Surya just finished her graduation, and Venkat Arya is finished his intermediate. This is my family who supports me all the time, and this is my extended family. This is a group of 30 doctors in Warangal, and more of them, where with one call they all come to my rescue. And these are my staff. I have a staff of 110 members, which I believe they are my extended family. This is a quote I like the most in recent times. When I asked what surprised him most about humanity, the Dalai Lama answered, "Man sacrifices his health in order to make money. Then he sacrifices money to recuperate his health. And then he is so anxious about the future that he does not enjoy the present. The result being that he does not live in the present or the future. He lives as if he is never going to die, and then dies having never really lived." I like this very much. Live your life when you are alive. Take home message. The hard work can never be substituted. Hard work can never be substituted. We should always be updating ourselves and our workplace. Now always maintain doctor-patient relationship with proper counseling and empathy. Be humble always with the patient, with the staff, with the with everyone. Professional jousting should be avoided at any cost. Always love your colleague and always maintain healthy relation with the professional colleagues, police, politicians, press, media and district administration. Thank you.
Thank you, Dr. Sudesh. You know, you are very hardworking, honesty and sincere person among our members, and you're a good leader among our association also. We have learned a lot of things in the association. Thank you so much.
Now I request Dr. V. Prasad Reddy sir and President TOSA and Dr. Vijay Bhaskar sir to come on the dais.
Sorry, sir. It is.
Dr. PNVSC Prasad sir, President TOSA and Dr. Vijay Bhaskar sir, Secretary TOSA.
Please spell Dr. Prasad sir name initial as correctly. PNVSV.
PNVSC Prasad sir.
Much of practice I learned it.